Professor Jones, thank you very much for coming to the
Pleasure.
Cambridge lecture. Can you please summarise your finding in terms of postpartum psychosis and bipolar disorder, your research finding?
So our group has been doing research into bipolar disorder for many years, and one of the things that's really fascinated me about bipolar disorder when I started going around and interviewing women for our study was how many women had a severe episode after childbirth, and how often that was the first episode that they'd had, or one of the really significant episodes that they had. So we became interested, and I particularly became interested in postpartum psychosis, and our research has really shown that this is a real issue for women with bipolar disorder. And we've done research that's shown that actually that women find it very difficult to find the information that they need. So what motivates our research at the moment is trying to understand better what that trigger is with childbirth, understand better how we can predict which women in particular and individualise that risk, and then how we can help them better. What is it that we need to do to help women understand and make those difficult decisions, and how can we intervene to try and reduce the risk? So that's sort of what motivates the work of the group at the moment.
Thank you.
What our research has really strongly shown is that the risk for postpartum psychosis, the severest of episodes, is in women with those kind of more severe bipolar forms of illness, what we'd call maybe bipolar 1. Other research that we're really interested in is to try to understand other factors that clinical services can use to try and predict risk better. Because we all know what it feels like to sit there in preconception clinics with women who have a history of severe mental illness, trying to make some of these impossible decisions that we have to try and help women make about whether to become pregnant or not, about whether to continue or stop or switch medication. So I'm a strong believer that if we can do all that we can to understand better what are those factors that predict risk, and be able to develop those kind of predictive algorithms so that we can predict those women that are very high risk or very low risk, that will really help us. One of the ways that we've gone and done that, and it's a paper that we published in the British Journal of Psychiatry in the last year or so, was looking at a couple of simple questions that we can ask women if they, in their second pregnancy, whether they have bipolar 1 or bipolar 2, how severe was the kind of the high episodes that they've had, and what happened as far as the psychiatric outcome in their first pregnancy is concerned. What we found was that those women with bipolar 1 who've had a postpartum psychosis, they were at very high risk, around a 45% risk of a postpartum psychosis in a subsequent pregnancy. Whereas for those women with bipolar 2 who maybe had a pregnancy and had no mood episode in relation to that pregnancy, in subsequent pregnancies their risk of postpartum psychosis was about 1%. So big differences there already, and we kind of feel that that is already clinically useful information. But actually what we want to do is, in the last few years we've been doing a prospective study, so trying to recruit women who are at high risk of postpartum psychosis because of their history of bipolar disorder, following them through to be able to look at many other factors, the quality of their relationship, the stability of their mood, whether they've had mood symptoms in relation to the menstrual cycle, all of these things that potentially could add to that predictive, to that individualisation risk. We would hope to do that. So bipolar study across the UK has been fantastic, and thanks to any services that helped us recruit from that. We recruited over 7,000 people to that, but one of the things that we're focusing at the moment is trying to do that specific high-risk pregnancy study for women with bipolar disorder. So again, if anybody, it'd be fantastic to hear about women that may want to find out more and potentially participate in that.
In terms of women risk, it seems like the risk is the highest the first week after delivery, which suggests it's probably obstetric teams, maternity will be involved at that point. So what do you think would help services, parental mental health services, to increase awareness?
And I think actually that it's a really good point, because the high risk time for the, and often women, and as I'm sure you know from your service, take some time to get through the system for it, because I think there's still some lack of awareness of what and sometimes, particularly in those early stages of a manic episode, it can be interpreted that women are doing well, doing better. So I think all the women that come into contact with women in that, particularly in those first few days and first few weeks after a baby, really need to be aware that it's not just postpartum depression. It's not just low mood that we're looking for, but women who are not sleeping, even when their baby are letting them sleep, women that are very active, women that seem very cheerful, that seem very irritable. These kind of symptoms are also really important to take account of. I think there's been some recent announcements that training in postpartum psychosis and postpartum awareness is going to be part of midwifery training, because it's probably in that, because women leave hospitals so quickly now, isn't it? It's probably the kind of midwife that's coming in before the health visitor takes over that's the key group to be able to recognise that. And I think other work that we've done shows that one of the terms that's used in the old literature about postpartum psychosis is it shows a kaleidoscopic presentation, so that it can vary very quickly. So I think those and that's kind of one of the lessons that's come out of the confidential inquiries, isn't it? So for women who have an onset in that first postpartum week or two, you have to take that account of the assessment, because the picture can change incredibly rapidly, and women can become as ill as we see people in psychiatry, where within hours. It's not a long chronic prodromal phase that often you see in these illnesses. So I think those are really important points for clinical services.
Thank you very much. Thank you.